So today we'll be discussing about the new guideline, the GTG guideline on SGA and FGR. So
Okay.
now, initially, they had given clubbed both FGR and SGA together.
Mm.
And what was the delivery time which they had mentioned previously for if there is SGA? When should you deliver according to the previous guideline?
By it depends, no, with
If the Doppler is normal.
whether the it if when it was normal by 37 weeks.
Yeah, so now they have changed. So if it is only SGA, first of all, they have changed
Okay.
the definition of SGA and FGR. They have reclassified it, and also they have increased the delivery. Like you can deliver by 39 weeks, up to 39 plus 6 weeks, according to
Okay.
the latest guideline.
Mm.
So now, what is appropriate for gestational age?
Mm.
If the fetal size is between 10th to 90th centile, right?
Okay.
This is like the previous guideline.
Mm.
Okay.
Okay.
Then small for gestational age.
Mm.
If fetal size is less than 10th centile.
Mm.
Okay, this is again same. However, growth restriction in the previous guideline, they had not defined growth restriction.
Okay.
Now they have defined growth restriction. First is when there is severe SGA according to the previous guideline, that is fetal size or abdominal circumference less than 3rd centile, right?
Oh, yeah. Mm.
Or if it is the fetal size or abdominal circumference less than 10 centile, but there are Doppler abnormalities.
Yeah.
Okay?
Mm.
So this is FGR. So
Okay.
FGR should have either the growth less than 3rd centile
Mm.
or with a Doppler abnormality with fetal size less than 10 centile.
Previously, less than 3rd centile means it was very
It was
small,
severe SGA, right?
and
Now they
less than 10
removed
means
that.
was SGA.
Yeah. Now they have removed that.
So this is new one.
Yeah, this is
If
new one.
abdominal circumference or fetal size is less than 3rd centile or 10th centile with Doppler. Okay.
Okay. And then they have classified as early onset and late onset. Early
Okay.
onset if it is before 31 plus 6.
Okay. Mm.
And late onset is after 32 plus 0.
32 before and after. Okay. Mm.
And
So
initially for
32 is
static
before.
growth, we were doing scans after 3-week interval, right? Based
Yeah.
on that part. Now they have made it 2-week apart. No forward growth, at least 2 weeks, 14 days.
Okay.
Understood? So quickly, can you tell me what is
So
appropriate for gestational age?
it was static growth for a period of over 3 weeks. Now now it is 2 weeks only.
Hmm.
Okay, ma'am. I'll say.
Okay, so what is appropriate for gestational age? Quickly.
Appropriate for gestational age is between 10th and 90th centile.
What is the difference between SGA and FGR?
So SGA is when the fetal size is, that is estimated fetal weight is less than 10th centile. What is SGR means? A fetal size or the abdominal circumference should be less than 3rd centile or 10th centile when there are Doppler abnormalities.
What is early and late
Early
FGR?
is before 32 weeks and late is after 32 weeks.
Okay, what is static growth?
When there is at least 2 weeks apart of static growth.
Okay. Now classifying as early and late. So this is similar, like because it is FGR, the other things are just like the FGR definitions. Early is less than 32, late is more than equal to 32.
Okay.
Now either the abdominal circumference or estimated fetal weight less than 3rd centile or umbilical artery there is AEDF or Doppler abnormality is there. Okay, so this is these are the points which are similar to the FGR definition.
Okay.
Or if the abdominal circumference estimated fetal weight less than 10 centile along with the Doppler abnormalities, which could be either uterine artery PI more than 95th centile or umbilical artery PI more than 95th centile or ADF, REDF, anything. Okay.
Okay. And here under for early FGR, it is less than 32 weeks with abdominal circumference estimated fetal less than 3rd centile or umbilical artery if it is abnormal. Whereas in this case, more than 32 weeks, you have mentioned only abdominal circumference or estimated fetal weight. How about the Doppler?
Again, Doppler also.
Okay.
It is the same only, so do not confuse in this. Okay.
Okay, ma'am.
The definition is like similar to the definition of the FGR that we have discussed. Only thing is early is less than 32 weeks, late is more than equal to 32 weeks.
Okay. And before static growth was over 3 weeks, now it is only 2 weeks.
Yes. Okay. Now at booking, what are the recommendations of screening? So, so according to the new guideline, all patients, all women should be assessed at the booking by 14 weeks for the risk factors of FGR. What are the risk factors? We'll be coming to that. So there is not much change. They are the same as the previous guideline. We'll be discussing about it.
Okay.
Then you have to record at the booking visit the birth weight, gestation, and the birth weight centiles. Okay. Then low PAPA, raised AFP, or raised inhibin A, they are major risk factors for SGA or FGR. Okay. This is something. Low PAPA was there in the previous guideline also. Now they've also added raised AFP, raised inhibin A.
Okay. Raised AFP and inhibin A. Okay.
Yeah. And in case there is low PAPA or raised beta HCG, then you have to give low-dose aspirin in these patients.
We have to give aspirin. Okay.
Yeah. Okay. Then regarding drug misuse, smoking, and what is a correlation? So they have said this question can be asked. So smoking is a risk factor. Okay. Previously they had characterized less than 10 cigarettes, more than 10 cigarettes. Now they have removed that criteria. Okay, they have just given it as a risk factor.
Okay.
We'll be coming to that table as well. So smoking, it definitely increases and drug misuse increases. And if you have to ask the patient to stop smoking in order to reduce the risk of SGA. So if they stop by 15 weeks of gestation, then the risk is similar to non-smoking women.
Okay.
So this 15 weeks you have to remember, it can be asked.
Okay.
And in case the patient is using e-cigarettes, there is still risk, although the risk is lower. And then you can check for carbon monoxide test and the emissions. And based on that, you characterize the risk pathway. Okay. And regarding caffeine intake, again, it is a risk factor. How much caffeine is safe? Again, they can ask. So up to 200 milligram per day or 2 mugs of instant coffee.
So maternal caffeine consumption of 300 milligram per day in third trimester. Oh, that is associated with SGA. Okay. So maximum upper limit is 200 milligram only. Okay.
Okay. So smoking, when it is stopped at how many weeks, the risk is similar to non-smoking women.
By 15 weeks.
Yeah. And how many cups of coffee you can take during your pregnancy?
2 mugs.
2 mugs or 2 milligram per day.
200 milligram.
Okay, very good. Then about COVID-19, they had not mentioned in the previous guideline. Now they say that if the patient was seriously or critically unwell due to COVID-19, then you have to assess for the weight in the first 14 days following recovery. You have to assess for the SGA. So you have to assess for the fetal weight. Do an ultrasound for the same. Okay. Then about how can you reduce the risk of fetal growth restriction? So by reducing smoking, that is one thing. Second is by giving vitamin D 10 micrograms per day or folic acid 400 micrograms per day from the preconception and up to first 3 months. That's okay. Then if there is risk of preeclampsia and placental dysfunction, then aspirin 150 milligram. And that also they have mentioned particularly in the guideline, it is most beneficial.
No more 75.
Right.
So aspirin is no more 75 milligram.
Nowadays it is high dose which is recommended, no?
150 only, no?
150, yeah. Actually, NICE recommends 75 to 150 milligram, but according to this guideline, particularly for the risk of preeclampsia and placental dysfunction, they have given a dose of 150 milligram, and that too it has to be taken at the night, starting from 12 weeks to 36 plus 6 weeks.
Okay.
Okay, and regarding the fetal weight estimation, they have mentioned what formula to be used. So you do not have to know much about it. Just remember the name in case they ask. It is the Hadlock formula, which looks like this, and it uses three parameters: head circumference, abdominal circumference, and femur.
Femur length.
Can you tell me what is the dose of aspirin and from what duration should it be taken in order to reduce the risk of SGA if there is high risk of preeclampsia?
Yeah, aspirin 150 milligram from 12 weeks to 36 plus 6.
Okay. So now coming to this table, which is given. So now they have, like previously they had classified as minor and major risk factor and other things, right?
Okay.
Now they have classified as low risk, moderate risk, high risk, and other factors.
Okay.
Okay, low means there is no risk factor at all.
Okay.
So in this also, at the anomaly scan, you have to see the fetal weight that you see in anyways. If it is more than 10 centile, then okay, you can just do serial symphysis fundal height measurement, and then reassess for all patients. You have to reassess at 28 weeks. So this was not there in the previous guideline. Reassessment at 28 weeks and after any antenatal admission. This was not there. So even in low risk, you have to reassess at 28 weeks. According to the latest
How
guideline.
do you know who falls under low risk?
If there is no risk factor at all for
So
SGA.
then every antenatal case should be reassessed at 28 weeks.
That you have to do one. You have to do serial growth monitoring, and you have to reassess at 28 weeks, or if there is any complication like hypertensive disorder or any other complication. Okay.
Okay.
So one reassessment for everybody. Then moderate risk factors. So they have classified as obstetric and current risk factors. So obstetric risk factors include if there is previous SGA, previous stillbirth, or appropriate previous stillbirth with appropriate for gestational age birth weight. Okay, that is a moderate risk factor, and previous stillbirth with SGA baby is a high risk factor.
So previous SGA, previous stillbirth of AGA, that is a previous stillbirth, even it was appropriate for gestational age birth weight. Okay.
And it is a moderate. If it was a SGA baby, stillbirth baby, then it is a high risk factor. This you have to remember.
Okay, so AGA stillbirth comes under moderate risk. If it was SGA and option to be previous FGR. Okay. Hypertensive disease in a previous pregnancy, previous SGA stillbirth. Okay, ma'am.
Okay. Then smoker any. Now they have removed that category of less than 10, more than 10. Any kind of smoker comes under moderate risk. Drug misuse, moderate risk. Age more than 40 years, more than equal to 40 years, or BMI less than 18.5 comes under moderate risk. Then any kind of eating disorder, bowel disorder causing weight loss, or bariatric surgery like gastric bypass surgery, or previous preterm birth or second trimester miscarriage, which is placental mediated. So all these are moderate risk factors. So in case these moderate risk factors is there, then you have to assess the history of placental dysfunction. Okay. And if there is placental dysfunction, what will you give?
Aspirin.
Yeah, you'll start aspirin, and then again at the anomaly scan you will do estimated fetal weight and then serial monitoring from 32 weeks every 4 weekly until delivery.
Okay.
Okay. And in these patients also you'll reassess at 28 weeks once.
Okay.
Okay. But from 32 week every 4 weekly. So initially they were there more than 3 minor risk factors, so nothing like that.
Okay. So for this, we should follow this only.
Yeah.
Okay.
So any of the moderate risk factor, you have to do first. You have to do at anomaly scan. You have to do the birth weight estimation. If it is more than 10 centile, no SGA, then you do one symphysiopundal height measurement at around 28 weeks, followed by serial scans from 32 weeks every 4 weeks until delivery.
Okay.
In case it is high risk, So high risk is any chronic, like these are mostly the major risk factors like maternal conditions, SLE, APLA, autoimmune condition, or if there was previous fetal growth restriction or hypertensive disorder or previous SGA related stillbirth. These markers, PAPA less than 5th centile, inhibin A more than 2 mom, alpha fetoprotein more than 2 mom, echogenic bowels, significant bleeding, estimated fetal weight less than 10 centile, or single umbilical artery. Okay. So in case there's hypertension, then you give aspirin. Otherwise, you have to do uterine artery Doppler in these patients. So previously in the major risk factors, you were not doing uterine artery Doppler,
Yeah,
right?
it's not
In
done.
this case, they have said that you have to do uterine artery Doppler, and if it is normal, then you have to do from 32 weeks every 2 to 4 weekly serial scan monitoring.
Okay.
If it is normal and estimated fetal weight more than 10 centile, then it is from 32 weeks. If uterine artery Doppler is normal and there is SGA, fetal weight less than 10 centile, then from 26 to 28 weeks you have to do.
Okay.
To 4 weekly monitoring. And in case Doppler is abnormal, then again from 28, but the weight is okay, then again from 28 weeks you have to do the monitoring.
Okay.
And in case the Doppler is abnormal and also the weight is then 10 centile, both of these are there, then you have to refer the patient to fetal medicine unit and individualized care has to be done.
Okay. So the previous umbilical artery Doppler assessment, all those not required anymore.
Yeah.
Should we forget about that?
Yeah, you have to forget about it because you get questions.
Okay. So this is only followed. Okay.
Okay. The other things are the same when, like, if the BMI is more than 35, fibroids, or congenital uterine anomaly. So they say in these cases, if the weight is okay, then you can do serial scans from 28 weeks if there is congenital uterine anomalies, and 32 weeks if there is symphysis. In case like it is unsuitable, you cannot, in case of BMI or high BMI or fibroid. Understood. Hello.
Yeah, yes, ma'am.
Understood.
Yeah.
Okay, so tell me, if the patient is a chronic smoker, how will you monitor?
If she is a chronic smoker, she comes under high risk. So uterine artery Doppler, when it is normal.
Smoker, it is moderate risk.
Which one?
Chronic smoker is a current smoker. It is a moderate.
You said chronic hypertension.
I said smoker.
Smoker. Okay. Smoker means moderate risk. So from 32 weeks, every 4 weeks until delivery.
Yeah. And before that, you will do symphysiofundal height measurement at?
Yeah, at 28.
At 28 weeks, and at 20 weeks, you'll do weight estimation along with the anomaly scan. Okay?
Okay.
Understood. If the patient is a known case of APLA, and you have done the uterine artery Doppler, which is normal, and estimated fetal weight is more than 10 centile. So how will you monitor this patient?
From 32 weeks, every 2 to 4 weeks until delivery.
Okay. And in case the estimated fetal weight less than 10 centile, normal Doppler, then?
From 26 to 28 weeks.
Okay. If abnormal Doppler but weight is okay, then?
Then from 28 weeks, every 2 to 4 weeks.
Okay. If Doppler is also abnormal and estimated fetal weight is also low?
Fetal medicine.
Okay. And in case the BMI is 38, how will you monitor?
BMI is 38. Less than 16 is moderate risk. What is the upper cutoff?
BMI comes under other category, no?
Yeah. Okay. Only less than 16 is a moderate risk. Less than 18. Okay. Then okay. So anomaly scan, and if the estimated fetal weight is more than 10, serial ultrasound from 28 weeks.
Okay. And if the patient has previous SGA stillbirth, Then how will you monitor?
Sorry, ma'am.
Previous
If
SGA stillbirth.
previous SGA stillbirth is a high risk. So uterine artery.
Okay.
Then if the uterine artery Doppler is normal and estimated fetal weight is above 10 from 32 weeks every 2 to 4 weeks.
Okay. Fine. Then, what are the investigations that you have to undertake? So this I've already told, that if uterine artery Doppler is abnormal and weight is less than 10 centile or estimated fetal weight less than 3rd centile, you have to refer all these patients to fetal medicine specialist.
Okay.
Then you also, in case it is early onset, very early onset SGA detected before 23 weeks of gestation, then you have to, these patients, you have to do the genetic testing also,
Okay.
which include microarray to detect micro deletions and micro insertions, and prenatal exon sequencing in cases if there is multi-system abnormalities or isolated short long roots.
Okay.
Okay. For early onset SGA, we were also doing these infection screen. No? So this is same. But they say you do only CMV and toxoplasmosis for all. They are
Okay.
associated with 5% risk. Malaria and Zika virus testing you do only in high risk.
Okay.
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 So in case of early onset, like if the SGA is at anomaly scan 18 weeks, what will you do?
If the SGA is at 18 weeks, yeah, when the uterine artery is Doppler is normal, we have to detect for micro deletion and micro insertion.
Okay. And in case there is a short long bones, then
Prenatal exome sequencing. What is that? Exome
the
sequencing.
complete genome sequencing.
Okay.
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 Okay, now coming over to management of SGA. So SGA, they say if it is just here the management they have classified as management of SGA and management of FGR. SGA is only if the fetal weight is less than 10 centile and you have excluded FGR. That is the Doppler is normal, right?
Okay. Yeah.
Then in those cases, then you have to do ultrasound every 2 weeks. Okay, this anyways you were doing, right? Ultrasound along with
So
umbilical artery
when
Doppler
do we
every.
say SGA? Only when the estimated fetal weight is less than 10 centile. Otherwise,
Yeah.
the Doppler is normal there. If suppose there is less than 10 centile along with Doppler abnormality, it is FGR.
Yes.
Okay.
When will you deliver if the patient is diagnosed with SGA Doppler normal?
Normal means by 39 weeks.
Yeah, at 39 weeks, and you will continue monitoring the Doppler, and based on the Doppler, in case it is to be delivered early, it will be decided. Okay.
Okay.
So this was SGA management. Now coming over to management of fetal growth restriction.
Okay.
Okay. Now you already have diagnosed FGR. That means either the estimated fetal weight or abdominal circumference is less than 3rd centile or it is less than 10 centile with Doppler abnormalities, right?
Yeah.
Then only you say FGR.
Sorry? When we
What
say FGR, yeah, when the growth is less than 10 centile with Doppler or when it is less than 3rd centile.
Yeah. So now your management will be dependent on when is it diagnosed, the FGR. If it is diagnosed for early, whether it is early onset first of all or late onset.
Okay.
Early is, how do you define early?
Less than 32 weeks.
Yeah. And late?
Late is after 32 weeks.
In all cases, you have to do for early onset every 2 weekly estimated fetal weight and every weekly Doppler. Umbilical artery.
Okay.
This is for all. Okay.
Okay.
And even for late onset, it is same.
Mm.
Every 2 weekly, you have to do estimated fetal weight and umbilical artery weekly. Okay, this so you will be doing
Okay.
until it doesn't develop into other abnormalities.
But before we were doing everything fortnightly, every 2 weeks. Here, how it
This has
is?
been FCR management has been changed. Okay. So FGR is always with less than 10th centile with Doppler abnormalities. No, actually it is the same only. It falls in the second column, right?
Yeah.
So it is same only. Initially you were doing for this
Here,
also you were doing weekly. Actually weekly
here
estimated fetal
estimated
weight and
fetal
weekly
weight is
Doppler. Now they have made it fortnightly, 2 weekly weight and 1 weekly Doppler.
this UA is umbilical artery only here.
Yeah,
So umbilical artery alone weekly we are doing.
yeah.
Okay.
Okay, so this is for both early and late. Now management, if it is diagnosed between 24 to 25 plus 6 weeks, you see the Doppler. In case it is AEDF, REDF, then you have to do twice weekly. CCTG, computerized CTG and ductus venosus.
Umbilical artery monitor minimum twice weekly with CTG. Okay.
Twice weekly is computerized CTG and ductus venosus. And in computerized CTG, you have to see for short-term variations. So I'll be coming to what these are basically very minute variability which is picked up on the computerized CTG. Okay. And in ductus venosus Doppler, you see whether the A wave is absent or not. Okay.
Okay.
So it is only AEDF, REDF. If it is diagnosed between 24 to 25 plus 6 weeks, then you can do individualized care.
Okay.
And in case it is if ductus venosus A wave is absent and short-term variability less than 2.6, between 26 to 28 plus 6 you deliver.
Okay.
You deliver early. Between 26 okay, and if it is between 29 to 31 plus 6, in case DV is absent or short term variability less than 3 milliseconds, you deliver.
Okay.
Okay, otherwise if these things are not there, okay, only FGR is there, then you can, in case there is REDF, you deliver by 32 weeks. If it is AEDF, you deliver by 34 weeks.
Okay, like before 32 to 32 weeks.
Yeah, but they have classified REDF, reverse flow, 32 weeks. You can consider from 30 weeks, but by 32 it should deliver.
Okay.
And for AEDF, 34 weeks, but you can consider from 32 weeks.
Okay.
Okay, and late onset, again same thing. If it is late onset, then you will do 2 weekly estimated fetal weight and weekly Doppler. And in case there is DV absent or short term variability less than 3.5, you deliver early. Otherwise deliver by 36 to 36 plus 7 36 plus 6, that is total of 37 weeks if only PI is raised. Okay.
Okay. If ST.
And if in case short term variability is less than 4.5 or AEDF, again you plan for delivery. Okay.
How much should be normal STV?
So normal, see, 4 to 5 is normal, less than 4 is low, less than 3 is abnormal, less than 2 is very abnormal.
Okay.
So that's what.
Normal. Okay.
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 Okay, so we'll just revise. So tell me, if the FGR is diagnosed at 28 weeks and it is AEDF, when do you deliver?
28 weeks and it is AEDF by 32 weeks. No, by 34.
Okay, and if it is REDF?
32.
If it is REDF?
If it by 32 weeks, we have to consider from 30.
Okay, and in case it is early onset FGR diagnosed at 28 weeks and you have done it is AEDF and you have done the ductus venosus Doppler, you've seen that A wave is absent and short term variability is 2.5. Okay, then
A wave is absent, short term variability is less than 2.5, you are saying. Then we have to which week?
You have to consider 28 weeks. You have to consider delivery, right?
Yeah, we have to deliver.
Yeah. Then, in case the FGR is diagnosed at 35 weeks and the PI is more than 95th centile. Otherwise, there is no ADF, REDF. When will you deliver?
PA is more than 95. I didn't get it, ma'am.
You have done this umbilical artery PI, which is more than 95th centile.
Okay.
When do you plan for delivery? The patient is 35 weeks now.
When it is more than 95, it is raised only.
When do you plan?
By 37 before, now by 39.
39 is only for SGA. Doppler abnormality is FGR. FGR you never prolong beyond 37 weeks.
Okay, so by 37.
Yeah, between 36 to 36 plus 6 weeks, you have to plan delivery.
Okay, 39 is only for SGA.
Yeah.
Okay.
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 Then, in case it is like you are diagnosing late, then in case Doppler abnormalities, like if it is 38 weeks, the patient, you see the Doppler uterine umbilical artery Doppler is raised, or if there is AEDF, REDF, then
Deliver if by 37.
yes, right.
37.
Already 38 weeks, no?
Yeah, between 37 to 38, this also varies.
So 30, what they mean is the patient, it was normal before. Now it
Okay.
is diagnosed late. The Doppler
Okay, it has been diagnosed very late.
SGA. But in
Okay.
SGA also you are monitoring, right?
Yeah, then by delivery, it should be delivered.
Sorry?
It should be delivered.
Yeah, it should be delivered. And SGA, when you plan for delivery?
SGA 39 weeks.
Okay. And what should be the mode of birth?
Cesarean.
No, it is cesarean for all.
For SGA, this is like a previous only.
Yeah, there are some changes for AEDF, REDF. Previously, also you were doing cesarean, but also for abnormal computerized CTG with short-term variations, abnormal short-term variations, or ductus venosus alteration, or AEDF, REDF, you go for cesarean. Otherwise, induction.
Okay.
Okay, FGR Doppler normal. When do you deliver?
FGR Doppler normal means 37.
Yeah, 37 to 37 plus 6 weeks. Okay, and otherwise, just for high PI, or if there is no AEDF, if these conditions are not there, you go for induction of labor or normal delivery. Okay.
Okay.
And magnesium sulfate, when do you give magnesium sulfate for neuroprotection? This is like your preterm guideline only.
Between 24 to 29 plus 6.
And you can consider up to?
Up to 33 plus 6.
Yeah, and steroids, when do you give?
Between 24 to 34 plus 6.
Yes, right. So this is like the preterm guideline only. Then now they have also given certain recommendation, like after delivery, what all should you do and how should you counsel for the patient for the next pregnancy. So for all FGR, you have to do histopathological examination of the placenta.
Okay.
Okay, and like in the postnatal period, once the placental histology report comes, and if there are, they should be screened for other factors like thrombophilia or something. If that was a cause, so the patient has to be screened in the postnatal period for the same.
Okay.
And you have what, according to the British Society of Hematology, you can screen for acquired thrombophilias in case it is indicated, like APLA, but for hereditary thrombophilia, routine screening is not indicated.
Okay.
Okay, so this was all about this guideline. Okay, clear? It is, I know it is a little complicated guideline,
So
but
like
you
I have to go through twice or thrice.
okay.